starting very shortly. At 5 past exactly, you will be mind blown by our lecture series from Zero to Neuro. I hope you guys are all excited. Take a seat, get ready, sit back, relax, and enjoy. Good evening, ladies and gentlemen. The time has finally come. On behalf of the Wits Student Surgical Society, I would like to welcome you all to tonight's lecture series, From Zero to Neuro. Prepare to be mind blown by a stroke of genius. It is my honor to introduce the brains behind the surgery, Dr. Maurizio Zorio. Dr. Zorio is one of the country's top neurosurgeons, practicing at the Mill Park Hospital with over 25 years of experience. He is one of the first neuros in South Africa to operate using novel gamma knife radiosurgery technology, the first of its kind in Africa. Dr. Zorio also takes a particular interest in Parkinson's and epilepsy. And without further ado, you've all heard of the Swiss Army knife. Well, I hand you over to the Italian Swiss Army surgeon, Dr. Zorio.
Thank you, everyone. I hope you can all hear me. It's an honor and a privilege to be able to give you this talk. I'm also very impressed by the Wits Medical Student Surgical Society. It makes me truly happy to see that there are a group of young people that are interested in the surgical specialities, and that this young group of people are super, super enthusiastic. So I hope that I can convince a lot of you about entering the wonderful field of neurosciences and particularly neurosurgery. Now, the talk that I am giving you today, after quite a long process of thinking, is titled really Personalized Brain Surgery, Will It Be Possible? Now, the background to this is that when I first trained in neurosurgery, we really positioned the craniotomy over the region of the tumor. We kind of knew the macroscopic anatomy, both of the cortex and the subcortical structures, and we tried to plan the resection of the tumor as safe as we could, but often found that our results weren't as good as we would have expected them to be. And obviously, over a period of time, technology has improved a lot of what we can see. And I think that the technology over the past decade or decade and a half has rapidly improved our ability to visualize the brain, the tumor, the fiber pathways near the tumor, which is making surgery more and more safe for us. But more than that now, we're beginning to understand how different areas adjacent and distant from each other in the cortex of the brain affects each other. And this can only be done by utilizing MRI scans and understanding brain networks. And this is what is going to be the most exciting advance in neurosciences in the next decade or two. And this is the decade that the young generation of people like you are going to be involved in. And this is going to be a truly, truly exciting couple of decades for you. Can I have the next slide, please? So when I look back and I say, what were the developments that have made it possible for us to personalize brain surgery to a large extent? Next slide. So the first one is neuronavigation. When I started in neurosurgery, we used to use anatomical landmarks to position our craniotomy flaps. So we had a whole lot of craniometric landmarks, which we could measure out on the skull, and this would give us more or less an idea of where a tumor in the parietal lobe would be, or where a tumor in the frontal lobe or temporal lobe would be. And we had to turn big craniotomies at the time because we needed a lot of anatomical landmarks to be absolutely sure. So neuronavigation came hand in hand with computer sciences and computer programs, and this has made it possible for us to accurately localize a tumor in the brain, structures within the brain, and therefore make the craniotomy smaller and also minimize morbidity to the patient. The next advance was the MRI sequences, specialized MRI sequences. When I was training, in my first year or two of training, we didn't have MRI scanners in South Africa, so we used CT scanning to plan our craniotomies. And then we got MRI scanners, which were very low field scanners. They were 0.5 Teslas, didn't have fantastic images, but already showed much better anatomy than we could see prior to that. But now with specific MRI sequences, such as diffusion tensor imaging and functional MRI sequences, we are now able to identify white matter fiber tracts in relationship to the pathology that we're going to deal with. Not only that, we are able to map functional areas of the brain, for example, speech. Now, we always were taught at medical school that speech was Broca's area, Wernicke's area, and the connections in between that. But in fact, it's not absolutely true. The distribution of speech within the left hemisphere can be huge. So functional MRIs have allowed us to see that. So it gives us an idea of the relationship of the tumor to a functional speech area or a functional motor area, or even to a network, that if we disrupt that network, the patient's not going to do that well post surgery. The next advance is that supercomputers and artificial intelligence, because with these, we are now able to crunch massive amounts of data to create wonderful brain maps from functional MRI studies. And then obviously, intraoperative neurophysiological monitoring. This isn't new. This was being done from about the 1950s and 60s, and then kind of they stopped doing it, and now it's come back into favor. But now we're not just monitoring for speech or motor function, we're monitoring connections of the brain as well. And this is done with electrodes and awake or even asleep craniotomies. Next slide. So let's look at neuronavigation. What does it do for us? It allows us to precisely localize a target within the skull. It allows us to make accurate craniotomies and smaller craniotomies. And nowadays, with integration of different modalities, we can even integrate an ultrasound to the navigation system so that we get a real-time updating of where we are in the tumor all the time. This makes total tumor resection much easier for us. And also, if we can continually update our MRI or our image of the tumor, we know where we are relative to important fiber tracts. And so it makes a total resection easier and a safer resection easier for us. Next slide. So here's a system. In fact, this is a system that I use. And the steps in obtaining that is really to do the scan, and then we place certain markers once we've positioned the head and register certain landmarks on the skull so that we can operate and navigate within that space that we've created and be very accurate. So you will see that the surgeon there is holding a kind of a wand in his hand, or a pointer, which is there if you can see my arrow, and that would tell you more or less where you are relative to the tumor. So you can plan your craniotomy in that kind of region there. Next slide. So when we look at the MRI sequences that are making things very easy for us nowadays to identify white fiber tracts, are the diffusion tensor imaging scans. And then we have two types of functional MRI scans. The one is a resting state MRI, and the second one is a task-based functional MRI scan. And then obviously, we're very lucky at Mill Park that we have an intraoperative MRI. So sometimes you get a complex tumor and you're not sure if you've got a total resection of the tumor because the white matter becomes looking a little bit more normal but doesn't feel like normal white matter, or you feel you're too close to certain fiber pathways and you want to bail, and you would like to do another MRI just to see what the resection cavity looks like. And we can do that immediately, transferring the patient into an MRI scan, doing the scan, finding out our new coordinates, and then continuing with the resection. We'll discuss a lot of these in further slides. New slide. Okay, so let's look at a diffusion tensor imaging scan of the brain. So this MRI technique allows us to track white fiber tracts in the brain. And how do we do this? Because it really monitors the diffusion or restricted diffusion of water molecules along fiber tracts. And we know that, for example, the cortex, which is densely packed, has water in it, but that water can't freely move around that easily, and it's very random in its movement. So it's going to have a different appearance to the white fiber tracts because they are mostly myelinated, and within the myelin sheath, water can travel along the myelin sheath in certain directions. And the technique that is used is really by putting magnetic fields at either perpendicular to the direction of the water molecule movement, and we can construct some beautiful fiber tracts of the brain. And you will know from your anatomy lectures, those of you who finished second year and in third year, you will know that the white fiber tracts, the white matter of the brain, consists of many different fiber tracts. And hopefully you will know of the U fiber tracts and the association fiber tracts and the projection fiber tracts, as well as the commissural fiber tracts of the brain. And these can all be highlighted for us. And we'll show you some example of that. So we can reconstruct these major fiber tracts in the white matter of the brain and then see the relationship of the tumor to these white matter fiber tracts. Next slide. So here's a case that we recently did. I can't show you operative images, unfortunately, because of the POPI Act. I didn't get permission from this particular patient to kind of demonstrate the video. But this is a young lady who has a cavernoma, which is a vascular malformation of the thalamus on the right-hand side. Now, from your anatomy, most of you will know that the thalamus is medial to the internal capsule, which carries your motor pathways. And we will see in blue here the projection fibers of the internal capsule with your motor tracts in them. And we can see that the tumor or the pathology is lying anterior to it, and on the next slide I'll show you it will be medial to this tract. And then we will see the association fiber tracts along the long tracts, okay, the superior longitudinal fasciculus, which connects frontal lobe to parietal lobe to occipital lobe and even to the temporal lobe. And we'll see the inferior fronto-occipital fasciculus, which connects the frontal lobe, base of frontal lobe, temporal lobe to the occipital lobe. And these are important in brain networking. And then the inferior longitudinal fasciculus here. So the structures that we were concerned about were mostly the fibers of the superior longitudinal fasciculus and the motor tracts. Next slide. So this shows the tumor again in red. This is the cavernoma. And these are the longitudinal fiber tracts, superior longitudinal fasciculus. And you can see that the motor system or the projection fibers of the motor system are lying lateral to the tumor. So that allows us to personalize the flap and as well as the tract that we have to produce in the brain to get to the thalamus in the safest possible way so that we can resect this tumor without any neurological deficits. Next slide. So when we look at functional MRI studies, in the past, how did we know where Broca's area was? This was really decided upon by looking at brain injuries in patients, surgical resections where people lost the speech. So it was anatomically diagnosed and anatomically found. Similar with the motor strips, similar with the frontal lobes. And there are a lot of classic examples of this. I'm sure many of you will have heard the story of Phineas Cage. Phineas Cage was a railway worker in the UK, probably in the late 1800s, early 1900s, who had a metal crowbar impaled through his orbit into the frontal lobe. And he survived that injury. But after having had that injury, he became a very placid, very carefree type of guy. His frontal lobes had been damaged, and we knew that frontal lobe contained a lot of your mood and executive functioning. And injuries like that gave us an idea of what the functions of the areas of the brain. And then Brodmann, he created a map of the brain, probably in the early 1900s, where he looked at the cortex and looked at neural connections within the cortex and labeled the cortex and gave each area of the known function of the brain a number. And we had these Brodmann areas, which included about 89 regions. But now with the functional MRI scans, there are at least 190, 200 cortical areas that have function and connect with other areas of the cortex, which may be adjacent to or even distant to that area. So how does functional MRI work? Basically, this technique measures brain activity by measuring the increase in the flow in an active area of brain. So if you are doing a particular task or thinking about something, the blood flow to that cortical area of the brain will increase. And what happens when the blood flow increases? The neurons utilize the oxygen and you get hemoglobin without oxygen, and that's what it measures. It becomes like a contrast agent to a large extent, deoxygenated hemoglobin. And this can give us a very good idea based on the strength. But in this technique, there's a lot of computer calculations. And there are two techniques that are involved. One is you give the patient a task to do in theater, and I'll show you some slides of that. And that is called a task-based functional MRI scan. And the other type is a resting state MRI scan, where you put the patient in the scanner, you ask him to look at a point and just relax. And then we see what the brain circuitries are. Now, the technique that's used here is called a BOLD technique. So it's blood oxygenation labeled a technique. So it's looking at the amount of oxygen carried in the hemoglobin and the blood flowing to that area. Requires a lot of images, a lot of recordings, and then requires a lot of manipulation of data to create the images that we see. And so you need fast computers to be able to do this. Next slide. So let's look at the task-based functional MRI. A patient is given a task, which is either a motor or a speech task to perform whilst he's in the MRI scanner. A BOLD image is then created based on the blood flow. Many times other areas of the cortex are also activated. And you can imagine this. If you're asking the patient to finger tap, he's got to think of what he has to do first, and there's a certain cognitive function involved in that. There's a cerebellar function involved in that, and all these little areas will light up. Or supplementary areas which are activated to perform that task properly. So currently, we use this image really to identify motor cortex and speech areas. And speech, importantly, when I'm doing temporal lobectomies on the left-hand side for uncontrolled epilepsy. Next slide. So here's an image of a tumor. So I don't know if you can see the arrowhead, but the tumor is this structure here, and here, and here. And the top group of images are images where the patient is given a task to perform, like finger tapping of the left hand. And now what you see here is this area lighting up. And it's a strong light up, this yellow color, and it's in the motor strip. So we know that this is the motor strip. Anatomically we know it, but here we can see what happens to the blood flow and oxygenation of the tissue in this area. And we can see the relationship of this tumor to the motor strip. So when I perform surgery on this, I know that the motor strip is behind the tumor, and I know that my resection is going to have to be cut a little bit short over here so that I don't create damage to this area and produce a hemiplegia or a paralysis of this patient. So when I'm operating him, I will expose the tumor and part of the motor area so I can stimulate the motor area all the time and the subcortical motor tracts to make sure that I'm not going to damage them. Now, this is a resting state MRI scan. And what this resting state MRI scan does, there is no task given to the patient. But here we are looking at what lights up, and you can see that his motor system is lighting up. There are a whole lot of networks that light up, but a very important system that's lighting up here, we can see there, is the supplementary motor area. Now, if I damage the supplementary motor area, his ability to perform a task from a motor perspective diminishes because it's almost like he doesn't quite know what to do, even though he has the ability to move his arm. He cannot do complex tasks, but it also affects speech because the supplementary motor area crosses over bilaterally. So I know now that this tumor is very close to the supplementary motor area in its medial extent. So now I can plan my surgery very well. I know where I can push the limits of the surgery and take more than the tumor out, because what I want to do, the more the resection, the greater the resection of tumor is, the better control I can get from for the patient, especially in low-grade tumors, which this was, a low-grade glioma. So if I can get a resection that takes normal brain as well, so you call it a functional resection of the brain, I take it to the limits of function, I can get a clear cavity with a prolonged survival of more than 15 to 20 years in these patients before recurrence occurs. Next slide. So in the resting state functional MRI, this is performed in the resting state. The patient doesn't require an increase or any task. And the region of interest, basically we place a seed at the region of interest. So it's an area that we map. So we need to know anatomically more or less where motor strip is, and we put that in, and then the bolt signal will be created after that. Next slide. So here's a patient who needed a temporal lobectomy for epilepsy. And this was, we needed to do a left temporal lobectomy for epilepsy. And on the image, your left is, or your right is the patient's left-hand side, okay? So when you view the image, your right hand will be looking at the left side of the patient. So here's a patient, top images again, these images. The patient is given a task to name objects, complete sentences, or count numbers, and we can see areas that are lighting up, okay? Many tasks with language require some frontal lobe function, so we can see that the frontal areas are lighting up. We can also see that the supplementary area is lighting up because that area controls all motor functions, including the motor function of speech. So in order to formulate his speech, he needs a supplementary motor area. But this patient is quite unique because both Broca's areas are lighting up here. Both Broca's areas are lighting up. So this patient has speech represented essentially in both hemispheres. So you do a resting state MRI on the patient and you put a seed where you think Broca's area is, and you can clearly see here that the left Broca's area lights up quite significantly, and we can also see there that the angular gyrus, which is the Wernicke's area, also begins to light up. So we can identify the speech areas of this patient, and we can see that part of the temporal lobe has some speech connections here. So when I do the surgery for this patient, I have to be very vigilant, wake him up, during the craniotomy, stimulate the area of the temporal lobe that I think is going to cause speech problems, see what speech problems are caused, and keep my resection away from that area. Next slide. Here again, it's another patient for temporal lobe epilepsy, and this one is much more easy because here we can see when we give him a language task to do, you can clearly see that the left hemisphere is containing the patient's speech. This is a very typical situation in most of us. Most right-handed people will have speech on the left-hand side, and 95% of left-handed people will have speech on the left-hand side, so the left hemisphere will be dominant for speech. But here we can see it very clearly and very nicely. And then again, with the resting state MRI scan, we can see again that the left hemisphere is really involving a lot of speech. So when I resect the temporal lobe, I've got to be very careful when I do the resection down the back here, because there I'm going to cause problems with comprehension and even naming of objects. Next slide. So now, earlier on I spoke about common brain networks that are being found with resting state MRI scans. Next slide. So here's the default mode network, okay? This is in all of us. So it involves the medial frontal cortex and the medial parietal cortex, which involves the posterior cingulate gyrus. There's the cingulate gyrus over here. That's the cingulum gyrus above the corpus callosum. It involves the posterior cingulum as well as the precuneus that is in front of the occipital lobe, which is this one here. This network is activated when a person is in a wakeful but rested state. And often they do internal thought processes. We all have that. If you're lying in an MRI scanner, you start daydreaming or wandering in your thought processes, thinking about yourself, maybe thinking about some patient who's ill or not doing so well. So this network is a very, very important network because we begin to see disruptions in this network in people with Alzheimer's disease. So they don't kind of have a sense of self anymore, and they don't know how to behave in public anymore, and they don't have feeling for other people. We see it in autism. Many autistic people are super bright, but have no social skills, cannot interact with other people. And using functional MRI scans, they find that this default network is not functioning normally. So damaging this default network can have a lot of effect on the patient's social behavior. And we didn't know that in the past. We would sometimes enter the precuneus to get into the lateral ventricle or to remove tumors from there. So we had created a problem with the patient. The patient was walking around, thumbs up, hands working, talking, but did he ever reintegrate into his job environment, or were his social skills less than perfect? We never knew these things. We congratulated ourselves on a very good job, but we damaged this network. Next slide. So what is the salience network? The salience network really just allows you to focus on certain things. So for example, if you're watching the sea and you happen to see a whale out in the distance, you will automatically focus on that animal. So what it does is actually involves your frontal cortices as well as your insular areas of the brain. And this network makes you aware of your inner self and also your external environment. And it also links up with your default mode network and also your central executive network. We'll come to all of those. But self-awareness, cognition, emotional behavior, sometimes we would do surgery and we would enter the insular area to remove tumors and disrupt that network, and then never tested the patients cognitively in the past. As long as they had motor function and they could count and talk, they were fine by us. But now we have these networks, and if a network is disrupted, we can understand the patient's pathology and behavior, and it's easier for us to take a tumor out through a standard approach. But if the network is still functional and there's a tumor deep to that network, you're going to have to use another approach and a new trajectory. And so our surgery is going to be trajectory based in the future. Next slide. The dorsal attention network is also the executive network, really. And it mostly connects the interparietal sulcus with frontal eye fields. So you can be geographically aware of what's going on. And it involves mostly orientating and visuospatial attention. So you operate in an area of the intraparietal sulcus, which we used to use as an approach to the ventricle, and the patient has visuospatial problems. For example, struggles to navigate home, forgets his direction to his place of home, spends 20 minutes driving around the suburb before he finds his way home again. So if that network is damaged by the tumor, it's a good approach because we're not going to cause worse damage for the patient. But if the network is very, very active and you damage it, there's no coming back from there. Next slide. So now let's look at some intraoperative monitoring, because that is becoming more and more popular in brain surgery now. The MRI image that we get allows us to plan an appropriate operative approach to the patient's pathology. We're aware of where his speech areas are, we're aware of where his motor areas are, we're aware of his major networks are. So now, when we go and remove a tumor in the region where the speech area, we can map it electrically. So we put the patient asleep, we open up the craniotomy, we wake up the patient, and then we stimulate the brain with an electrical field. And my technique is using a bipolar electrode, 60 hertz, and we increase the voltage or the amperage from 2 milliamps to about 10 milliamps to see if we get a response. And we test it 3 times. And if we get a response, we map that area, we mark it. We put a little piece of paper, a little block of paper with a number on it, and we mark it. And then we know where our limits are and we know where we can enter. Now, we talk about speech areas. So I had a patient about 15 years ago, a young lady who was an advocate. We presented with an epileptic fit and was found to have a low-grade astrocytoma of the inferior frontal lobe on the right-hand side. And she's a left-handed dominant person. So when we did the functional MRI on her, we found that her speech was predominantly on the right-hand side, in the region where the tumor was. So we were aware of this, so we did a sleep-awake craniotomy. We woke up, we resected the tumor while we were testing speech, but we were not able to resect the entire tumor because at the posterior limits, we were getting speech arrest and difficulty with speech. So we had to stop the operation at that point and then follow her up. I followed her up another 8 or 9 years after that, and the tumor started regrowing slowly. And then we had to go back. Obviously, it was showing signs of growth, and we were afraid it was going to become more malignant or higher grade. And so we took her back to surgery, and we remapped her speech area. But on this occasion, we were able to remove the entire tumor without affecting her speech. Her speech area had moved back a centimeter from where it was at the previous surgery. And so sometimes in slow pathology like low-grade astrocytoma, the brain is capable of rewiring itself. And this is what's happened in this lady. The brain rewired itself, so speech was in a different area to where the tumor was, and it allowed us 8 years later to resect the tumor totally. And she's still alive and well today and still practicing law today. So it allows us really intraoperative monitoring to reduce the morbidity associated with surgery to eloquent areas of the brain. Next slide. Sorry, next slide. Sorry, next slide. I think there may be a problem here. Can you hear me? Hello, can you hear me?
We can hear you, Doctor.
I just want the next slide. It's not moving on.
Yes,
Okay. Okay. But can I continue talking so long? So not only is this going to be important in surgery and post-surgery, but it's going to be very important in rehabilitation of patients who have minor deficits, because nowadays we can use transcranial magnetic stimulation of the brain. So when we know the circuit that has been partially disrupted, we can stimulate another circuit which is connected to that and rewire the brain to a large extent. And this is going to be the next important thing, because patients will have much better rehabilitation. As we understand the brain circuits more and all of its connections, we will be able to rewire some of the circuits and help patients recover. So a patient who has a stroke in the supplementary motor area, who is having difficulty with hemiparesis, cannot coordinate the function, we can rewire that circuit because we know that that circuit is bilaterally representative. So we can stimulate the area to rewire them with a magnetic field, which creates an electrical field, which stimulates the neurons. So rehabilitation medicine is going to become something where we can really do something quickly for patients who've had damage to certain networks. So this is going to be very, very important in the future. So with the stimulation, we can enhance the brain plasticity to a large extent. Next slide. So in conclusion, what we are looking at is neuronavigation, and that is going to expand with computer technology. Functional MRI scans are going to become more and more common, and there is currently a huge international consortium that are developing what we call the brain connectome, the connectomics of the brain, very much like the Human Genome Project. We will map every cortical area and all its connections, and we will be able to identify how each area of the cortex communicates to another area of the cortex and make surgery, as opposed to what we had in the past, which is really certain approaches to particular areas of the brain. The approaches are going to be tailored with modern technology. And this is going to revolutionize neurosciences. Psychiatry, for example, is going to be revolutionized by this. And already today, they look at depressive illness in patients and can already, with functional MRI scans, identify subsets of patients that will be unresponsive to medication. Some of these patients will be responsive to rewiring the brain in certain circuits that are damaged in depression, to the extent that the patient can be significantly helped. So this is going to involve all neurosciences, all neurorehabilitation, and this is why I think in the near future, personalized brain surgery is going to be the future of neurosurgery. And remember that everyone's brain is not wired in the same way. We would understand all of those things in the past because we used anatomical diagrams. Now we are using functional images of the brain that will tell us how your brain is wired differently to my brain from motor perspectives, speech perspectives, and many, many other things. So that is what is going to revolutionize medicine. And I'm sitting near the end of my career in neurosurgery, and I'm just getting the taste of this. And I have minimal computer skills, unlike your generation of guys. And my suggestion to you is that those of you who are keen in the neurosciences, get to read a little bit about the functional MRI scanning and resting state MRI scans, because those are going to be the future, and you are going to be the future of neurosciences, those of you that choose to do neurology, neurosurgery, psychiatry. Thank you for the opportunity to give the talk, and I'll be open for questions.
Thank you, Dr. Zorio, for a truly riveting, informative, and truly axon-firing lecture. So, like you said, at this point in time, I'd like to open the floor up for questions. These were posted by our attendees and those who RSVP'd for the event. If it's all right with you, I'd like to start with the first question. So, the first question reads, has neurosurgery broken the boundaries of what is available in public healthcare as compared to private healthcare? How do we help work towards bridging that gap? And what is the prospect of future robots, AI assisted neurosurgical procedures looking like in South Africa specifically?
I think that with all of these technologies, the cost is going to be the limiting factor to a large extent. And even in the private sector, we don't have access to all of it as yet, because all of these software programs cost a phenomenal amount of money. So, so I'm not quite sure about the public sector at the moment, but I know that they're beginning to do some awake craniotomies in the public sector. I believe that the public sector has very good quality MRI scanners. It just requires the radiologist to be enthusiastic and to be able to take on the different sequencing, because there's a lot of sequences and that requires a lot of manipulation of the MRI scanner to do that. And you need people that are enthusiastic and are willing to do that and interpret all of these scans. So I think it is possible in the public sector. I think it will be possible there, like it's possible in the private sector. In terms of robotic surgery, the cost for us at the moment is extreme. I think a robot which is being used in spine surgery, for example, to identify the pedicles and position you over the pedicle in the spine to make that less risky of damaging a nerve root or whatever, costs in the region of about 3 or 4 million euros. And it's you need to do a hell of a lot of spine surgeries in order to justify the use of that robot at this point in time. And all it does is it pinpoints you to the area. And it puts a cannula there, and then you drill down and you still do the things. So artificial intelligence definitely is going to be a big revolution in neurosurgery, because that is going to be mapping the brain. to a large extent. A robot performing actual surgery in the brain, I'm not sure yet, because you still need that human touch, that ability to be able to say, I need to now stop here or whatever. So I'm not quite sure about artificial intelligence and a robot operating on a person's brain. I think that's going to require a massive paradigm shift and a massive trust shift on behalf of the patient. Because when the patient comes to surgery with me, they believe that I'm going to take every single precaution to make their surgery safe and pleasant for them. When they see a robot, it's cold steel. They're not going to fiddle with it. So I think maybe the surgeon will drive the robotics. I don't know. But the cost will be horrendous. That's all I know. So I don't see it in the future in South Africa, not for the next maybe 15 or 20 years.
All right. Thank you so much. So our next question is, how has research in the fields of neuroplasticity and stem cells influenced neurosurgery?
So I think research on neuroplasticity is definitely influencing neurosurgery tremendously. Years ago when I trained, there were certain things, there were certain little rules, The adult brain never really recovers from a severe injury. Or if you damage Broca's area, or if you operate near Broca's area, the patient never recovers speech. But I know for a fact, experienced numerous occasions in patients with low-grade tumors in the so-called Broca's area, where the mapping showed us that was a speech area where I've had to cut short of the surgery and then come back 8 or 9 years to operate, and I've seen it in my own eyes. It's like watching evolution. The speech area had moved. It had rewired itself. So, and this work is ongoing and ongoing. So, there's certain areas you can't. If your speech area is there and it lights up and you cut it out acutely, there's no recovery of that. Okay, this occurs with slow pathology. So plasticity, for example, in patients with severe depression, where you can rewire certain circuits that are not functioning by stimulating other circuits, is a real possibility, which is going to revolutionize a lot of this. Alzheimer's disease, understanding what circuits are being damaged and rewiring them can temporarily improve that patient, make them functional for a period of time. So I think plasticity is a phenomenal thing. In terms of stem cells, it's kind of flat at the moment. In my reading, certainly in neurosurgery, there was a big movement for stem cell implantation in patients with Parkinson's disease, but that failed. Then there was stem cell implantation for spinal injuries, and that seemed to fail. So I think there's still a lot of research that needs to be ongoing before stem cells become an important aspect of our treatment. However, more and more research is going genetic, so it is possible that in the future that we will target the treatment of brain tumors, knowing their genetics, with viral vectors, and they will transport the chemo agent directly to the tumor cell, and it will target the tumor cell and no other cells around it. And I think that is also a very exciting field, and I think that will develop, and most likely I'm not going to see it in my career, but a generation of your guys, you're going to see a lot more of genetic manipulation of illnesses in medicine.
Thank you, Doctor. Very, very, very interesting stuff, and I'm sure a lot of us looking to go into the neurosciences are quite excited for the future and all that it holds. The next question is more of a personal one. When did you know that you wanted to specialize in neurosurgery? How long is the journey ahead, and what are the steps to becoming a neurosurgeon?
Okay, so I wanted to be a neurosurgeon in second year medical school when I studied neuroanatomy. So we did our neuroanatomy block, and I fell in love with the nervous system for some reason or other, and I found it to be, I always call it the main switch. When people ask me, neurosurgeon, what is a neurosurgeon? I'm just an electrical technician that plays with the body's main switch, and that I always found very, very fascinating. And because I had a surgical bent, I was fascinated by the anatomy of the brain, this lump of tissue that can perform so many tasks, and we don't begin to understand it. So that was my fascination. The other thing is that, the neurosurgery is unlike any other field of medicine. It's, you've got no leeway for mistakes or so. So I think that it's almost like the skydiving of sports, the skydiving of medicine. And that always attracted him. Maybe because I'm a bit of a psychopath, I don't know. But neurosurgery was what I wanted to do from second year onwards. And then obviously the journey, I can only tell you my journey. You see, we qualified in medicine, did my internship. In my day, we had to do 2 years of outside time before we could start specializing. And my 2 years were unfortunately spent in the military. 2 years where I did military medicine and then came back and started my neurosurgical course. And it was a 5-year course at that time, of which one of those years were general surgical years. And then after that, the journey continues, because I've always had to keep up to date, because it's a field that's changing tremendously all the time. So now I have to understand what a resting state MRI is, what a tractography is, new approaches to brain tumors. Ports. We're using ports, tubes, to get to tumors, to disrupt the brain substance, and we're going intravesicular, not transvesicular. So there's just so much evolution currently in neurosurgery. For me, it's very, very exciting, and I'm seeing the end of it, and it's making me very, very depressed, because there's still so much learning to be done. So I think the learning in neurosurgery never stops. And the journey that I've had over the past, so from 1989 to now, is just been a phenomenal journey of, look, neurosurgery to me is a passion, and every year I learn something new. I'm never bored by it, by the speciality, but it is psychologically very, very taxing, because you must understand that many of your patients are not going to do as well as you, not many of them, but some of them are not going to do as well as you expect. And that's a very, very stressful thing, because you always wonder whether you could do better. You always pray to God to give you better and better and better skills, but that's not possible. And your high-grade tumors all die. Even if you get them to survive 10 years, they eventually die, and you develop a relationship with the patient and the family, and it hurts. So there's a lot of pain involved in it. But in terms of the knowledge, the learning, the ability to learn, I'm never bored with neurosurgery. I learn all the time, and I'm finding it more and more and more exciting. And in fact, I'm jealous of you guys, because I know that one day when I'm in diapers, you guys will be doing things that I never imagined. It's growing so fast. So it's a long journey. It's a beautiful journey, and I would recommend it to youngsters.
Thank you for sharing, Dr. Zorio. I said it at the beginning of the talk, but I'll say it again. I think a lot of us looking to go into the neurosciences really, really look up to you and people in your field, and we're really thankful to have people like you setting paths for us and learning new things on a daily basis. The next question is, I think you've already spoken to some of it, but I'll read it in full. How do surgeons manage to operate on a brain without damaging it? It's so friable. And how are the skull bones resutured?
Okay, so I don't think the brain is very, very friable. It's pretty easy to operate on the brain, provided you know the anatomy of the brain, because without a good knowledge of the anatomy, and it's not only just a knowledge of knowing where the frontal lobe and all of that is, you've got to know what is deep to that area that you are operating on. it becomes quite easy to operate on. Once you know the anatomy and you know where your important structures are that are going to cause problems, it becomes easy to operate on the brain. Often operating on the skull base, for example, space becomes an issue. You know, big tumors on the skull base, you've got very narrow corridors to get to them. It requires a lot of patience. And, you know, you've got to understand, I think, anatomy. If you know the anatomy intricately of the brain, you can do relatively safe surgery on patients. So it's not that friable. I think if you don't know where you're going and you damage the main switch, that's a problem. That's a problem. How do we put the skull back together? Well, we use little microplates. We screw it in with little microplates. Little plates with screws. And it seems to heal and it regrows bone, because when we have to go back for a repeat surgery a year or two later, you have to cut again. You have to use the craniotome to cut it.
Thank you, Doctor. So our next question is, it is said that neurosurgery can be a very demanding and yet profoundly rewarding yet profoundly rewarding. Neurosurgeons may just be the coolest of all surgical specialists. What is the most rewarding thing about neurosurgery, and why are neuros so elite?
I don't think, I think neurosurgeons, I don't know, you know, I can only talk from my aspect of neurosurgery. To me, it's just the most phenomenal field. It's a rapidly growing field. It's a field that many people believe is untouchable. It's not. Neurosurgeons are not elite. We're not particularly cool people. Some of us, I don't stress too much at surgery because I plan mentally for those kind of things. But some guys are quite irritated in the operating room because they're stressed. So we stress most of the time when we're operating on a patient, because you're always thinking of what can go wrong and what damage you can do to the patient. So I think I would say it's a very humbling profession. You know, every time I thought that I could walk on water, God punished me severely and brought me back down to earth very, very quickly. So the beauty of neurosurgery to me is that it humbles you, because this brain that we're beginning to understand a little bit of really is, we're nowhere near understanding the full function of the brain, because I believe every single area of the brain is connected to some other area. So there is no surgery that the patient doesn't lose some function. It's just not noticeable, and we do not have the tests that are able to test all of those functions of the brain. So you're always causing some damage, but it's relatively minor in our opinion. But if you had a battery of tests, you would find that most patients will have some damage and some circuit disruption from our surgery. But I think it's exciting, it is difficult, it is very stressful, and it is extremely rewarding when, I mean, I had a young girl, 19-year-old girl with a huge acoustic neuroma, where other neurosurgeons said, look, go find an idiot who's prepared to operate on this, you know, and the idiot was me, you know, but when I operated on that tumor, and she was well post-operatively, and by the way, that tumor took me 19 hours to remove, and her face was working, and I looked at it and I said, what better gift can you get in life? What better gift can you get in life to see this young lady that was turfed away by some guys? She was told that she must find an idiot to operate on her because he will not touch her. And this girl comes back to post-op and she's perfect and she's going back to university. And I know that she's going to have a very long life. That's a gift that no one can give you. You know, it's something that you lie in bed at night and you say, wow, what a present that I got. I'm happy. The girl's done well. So but it's a very, very stressful profession, and it's not for people who stress very easily to a large extent. You know, and it's not for people who are scared of working hard hours, because that's it. You know, your time is not your own time. And I'm now at the kind of age where I'm not doing any trauma because I've got youngsters I'm mentoring, young neurosurgeons that I'm taking them through the paces and developing them. But up until now, my time was never my own. You know, you would sit on a Sunday and there would be a subdural to do and you'd have to go out and do it. Or you would have a heavy day in theatre and you go to bed at 1 a.m. and at 3 a.m. you have to get up to do another subdural. So it can get very, very difficult from that point of view. But a more rewarding speciality, I don't believe exists.
Thank you so much, Doctor. The next question is, could you please describe your most interesting and your most complicated surgery you've had to perform?
Sure. Most interesting and most complicated surgery I've had to perform. So there are a lot of complicated surgeries that we perform. That picture of that cavernoma that I showed you, it's a very complex surgery because we are operating on the thalamus. The thalamus is a deep structure in the brain. And accessing the thalamus, there are a couple of routes that you can access it. But in order to get that cavernoma completely out, I need a direct view of the cavernoma in its long axis to be able to get it. Because if I come from the side, I can't see around the corners, and it's likely that I'm going to leave some behind. So that was a very complex case, which required what we call a tubular retractor. So it's really a dilating tube, which we put in to the region of the thalamus. So remember in that image that the motor pathways were on the lateral side of the tumor, and the superior longitudinal fasciculus was on the lateral side, and we approached it from a parietal approach, and we used the tube to go in. So the tube was 2.3 centimeters in diameter, and that's the size of the tube that we were able to work through. And so we were able to get it all out, and the postdoc scan looked beautiful, and it was wonderful. And then that young girl with the big acoustic that I spent 19 hours on was an exciting case. But my Parkinson's patients, which is relatively easy surgery, it's really making a burr and putting a lead into an area of the brain, requires a lot of planning. But when you see a end-stage Parkinson's patient who cannot eat, cannot go to a restaurant, he's shaking so much, and you put those leads in and he comes to you for the post-op visit, and the guy's able to eat and he's got minimal shaking and he's reintegrated himself into society. It's a simple operation that gives phenomenal amount of pleasure and excitement. You know, I mean, there've been some very, very difficult cases. You know, sometimes we get cases like an AVM where you get the AVM ruptures, and that's a disaster because it's bloody and messy. You can't see what you're doing. You've lost control of the operation, and you feel like everything's going to end at that point, and you manage to get control of everything. So there are. So my aspect is, so I do a lot of neurosurgery. I like the brain. I don't like the spine so much. So I don't like doing fusions of the spine, especially the lumbar spine. They hurt my hands. They're gross operations. I call them orthopedic operations. But we have to do everything. So I have my biases. I don't like the spine as much as I love the brain. The brain excites me, the spine less so. But you have to do it. Trauma used to excite me when I was young. As I got older, I got less excited by trauma, and I got more and more fatigued and tired. If I did a case at 2 a.m. in the morning, now if I do a case and I go to bed at 4 o'clock in the morning, my next day and the day after that is completely messed up. I can't bounce back. I can't recover easily. So as you get older, you can't recover. But I don't think there's any horrible operation in neurosurgery. I just think there are long operations and there are very complicated operations, and there are certain operations that carry much higher risk to the patient, and you've got to carry them through it.
Thank you so much, Doctor. On behalf of the Wits Student Surgical Society, we would like to thank you for taking time out in your very, very neurotic schedule to be with us here tonight. It's always a pleasure, and we hope to see you again soon. We would also like to thank all our attendees for signing on with us tonight on YouTube, and all who made this event possible. Please follow us on our Instagram, our Facebook, our channel. Please subscribe so that you don't miss out on our lives. Thank you, everyone. Have a good evening. Stay safe, and God bless.
Thank you, everyone.
Thank you, Doctor.
Cheers. Bye. Be well.